So today it's my honor to introduce you to from Liverpool. Over to you, Dr. Satish.
Hi, good evening, everybody. It's early evening here, but late evening in India. I hope you all are keeping well in view of current COVID-19 situation, and you all are working hard, but keeping safe yourself and healthy. First of all, thank you, Dr. Gopal, for inviting me for this very noble cause, teaching students and helping to create the new generation orthopedic doctors all over the world. And as I'm aware that this is being viewed all over the world in orthopedic fraternity. Now, I have been told initially that this is mainly focused towards the FRCS orthopedic examination, mainly for the registrars and trainees in orthopedics. So my talk will be basic, sticking to exam-oriented stuff around the hip joint. And I'm going to talk about it throughout the course. So this is my place where I'm placed slightly outskirts of the Liverpool Western Hospital, which is a very busy district general hospital. As Dr. Gopal mentioned, we are the lead employer for the Mercy Deanery training, as well as regional plastic center along with orthopedics. So orthoplastic works quite busy here along with open traumas or open injuries. And I have got nothing to disclose. So I thought that it would be beneficial if I set 5 questions as FRCS Viva questions, but they are relevant to all practitioners as well. And if you are able to answer these questions towards the end of our meeting, then hopefully that would solve the purpose of this session. So these are the 5 important questions relevant to the total hip arthroplasty, and we all know the indications and different types of arthroplasties which are offered for hip pathologies. And to start with, and again, I'm saying I'm going to stick to very basic, relevant to the biomechanics and how the total hip arthroplasty works and how it is relevant and how it should be dealt with. So when you are considering or offering total hip arthroplasty, certainly you have reached the diagnosis and you have already done the non-operative treatment measures. Patient has exhausted all of them, and you're reached to the point that you're offering the total hip replacement for the hip pathology to the patient. So which are the factors which you will consider before you offer or before you plan for total hip replacement for a patient? Which are your preferable approaches, which approach or which surgical exposure you will use, and you need to know the merits and demerits of it. Which total hip prosthesis, because there's a wide range of and variety of prosthesis available in the market. And certainly in NHS, we are ruled by the guidelines and protocols and the evidence base. So certainly that will help you in the exam. How much you're worried about, or how will you assess the patients coming with the total hip arthroplasty in the follow-up in the clinic? And if patient coming with the painful total hip arthroplasty, what you're worried about and how will you go clinically to rule out the reasons for it? And what are the different modes of failure in all types of total hip arthroplasty? But our focus mainly would be having cemented total hip arthroplasty here, because it's a very vast topic and it's very difficult to cover each and every aspect of total hip arthroplasty. So to start with example, this is a 63-year-old gentleman presented to us with ongoing symptoms of right hip pain, as you can see on the x-ray. Ongoing for 3 years, but his symptoms got worse in last 6 months. He's smoker and alcoholic, and there's no other medical relevant history. He has taken all the non-operative measures and in the form of analgesics as well as the physiotherapy. But now he has reached to the point that his activities of daily living are badly affected. And he's quite active in his life. He's quite mobile, leads independent life. He's still working, and his job is mainly driving the wagon vans and traveling from point A to point B. So this is a brief summary of his history. So before we proceed, I want to know what is your thought about it. This is a patient who has exhausted all non-operative measures, and you're thinking about what kind of treatment you're going to offer. Certainly, there's no doubt that you have to talk about total hip replacement, and because that's what you reach to the point. Now, what are the thoughts about diagnosis? What should be the underlying cause for this? And you should rule out all other underlying causes for developing this arthritis. So it could be the primary osteoarthritis, it could be secondary to avascular necrosis, it could be any other cause. But as you all know, you need to know all the relevant causes for osteoarthritis. Uh, Either it could be idiopathic, primary, or secondary causes. So what should be the plan when you're offering the total hip arthroplasty? Which factors will you consider when you are offering or considering for total hip arthroplasty? So first, divide it into the patient factors, surgical factors, which is yourself surgical skills, approaches, techniques, and the local factors relevant to the prosthesis. So it is very important because especially with the Asian patients, the functional demands are different from the Western world. Age of the patient, I mean, in this case, is relatively young. 63 is considered very young in at least Western world. And functional demands, he's still working. So obviously he's going to be very active, and he wants a pain-free joint and mobile. However, in our Asian population, the functional demands are slightly different. Maybe their activities of daily living are slightly different, such as praying or squatting. Not everyone has got Western toilets. So these are the things which you need to think of or consider when you're talking about total hip arthroplasty, because this is very important. And in the very beginning, you need to discuss all these measures with the patients before we discuss about total hip replacement procedure. And before you proceed before you offer surgery, you need to rule out some certain underlying conditions, which are the contraindications, whether genuinely you can offer the surgery, whether genuinely you offer this procedure or not. A is infection. It's very important, whether your patient has got any other focus of infection in the body, such as chest infection, urinary infection, or infection itself in the hip. And there are a number of causes why patients can have primary infective pathology in the hip, septic arthritis of the hip joint. And Asian population, maybe tuberculosis. It's not that much relevant in Western world, but still we do get some cases of tuberculosis in UK. But tuberculosis of the hip joint is not very common, but you might see some cases in Asian population. Neuropathic joint, and this is one of the relative contraindication, because you don't want to operate on someone who has got a neuropathic, because it's not going to solve the purpose of your hip arthroplasty. And the major indication or main reason why you're offering the hip arthroplasty, A, is to improve the pain. You can't guarantee that your pain will be 100% gone or it will be pain-free, but you are trying to improve the pain and improve the mobility. So someone with a neuropathic joint, I mean, obviously, which is going to go worse, it is going to fail, day one failure, if you offer the total hip arthroplasty for this patient. Patient compliance, it's very important whether patient is going to follow all the instructions, all the precautionary measures which you're going to advise the patient after having a total hip arthroplasty. Although total hip arthroplasty has been a very, very successful joint replacement surgery all over the world, it's one of the most successful amongst all joint replacements. Still, it has got its own limitations. Now, especially it is more relevant to the Asian population because they can't squat, they can't sit on the floor for praying. And these are the limitations they need to understand. If patient is not compliant and they're not going to follow your instructions. For our Western population, it is very relevant. Someone who is very alcoholic or drug addicted, obviously there's answer is no for total hip arthroplasty. You can't legally say no, but obviously you have to try and find out other ways and means of treating these underlying conditions. Obesity is a relative contraindication. I wouldn't say obesity is the contraindication, but certainly we do follow the protocols and guidelines that we do give time to the patients to reduce the weight by different ways, either through the diet or weight reduction regime, or there are different ways of dealing with it. And high BMI is one of the relative contraindication because the outcomes are not that great. So when you are talking about giving a total hip arthroplasty, you are not just thinking about a year or 2 year or 5 year down the line. You have to think long term. How is going to be the survival and effectiveness of your total hip arthroplasty? Other comorbidities, patients with severe heart, lung diseases, with very high risk for anesthesia or surgery, certainly you will think about it. You will have to have MDT approach. You will discuss with anesthetic, medical team, or cardiologist, depending upon the conditions. And if patient has got any associated neuromuscular disorders. Now, again, the neuromuscular disorders, I'm talking about severe neuromuscular disorders. And we do see here patients with multiple sclerosis. And certainly we don't offer or we don't treat these with such a severe major operations. But the neuromuscular conditions, such as maybe in Asian population, we will see poliomyelitis, but here we do see more patients with the cerebral palsy. It depends on the severity of the disease. You need to discuss with the patients or the family and then decide. Patients with learning difficulties with some associated disorders, again, that is a multidisciplinary approach. You have to think in perspective. What are the patient's current problems? What are the patient's functional demands? And how best you can help to the patient. Now, coming to the surgical factors, it is very important that surgeon who is offering this procedure should be aware of their own limitations. Hand surgeon, foot and ankle surgeon, or any other subspecialty spine surgeon, they will certainly will not look into it and they will not talk about it. But you need to know your own limitations, how much you can offer. Someone coming with a very dysplastic or abnormal anatomy around hip, you will have to know your own limitations. If you feel that you can't deal with that problem, you need to be honest with yourself and with your patient, telling that, look, this is a complex problem, or this is a complex hip replacement, which I don't do, or I don't have exposure of it. And I'm going to refer you to the expertise who can deal with it. And that honesty pays you a long way, because that is very important for yourself and the patient. Now, you need to know which approach you are going to use. If you've been a hip surgeon, then you are familiar with all the approaches. And the most commonly used approaches in UK, it's for fractures, we do use Harding's approach. And for total hip arthroplasty, we do use posterolateral approach. So you need to be familiar and you need to know which approach and what are the pros and cons of each approach. Now, Harding's approach is good for fractured patients with total hip arthroplasty. There are certain indications for fractured neck of femur total hip arthroplasties. There are contraindications and some advantages of it. Advantage of it will be less damage to the, there is no risk of sciatic nerve damage. You're not touching the rotators, short external rotators. However, there is increased risk of having a heterotrophic ossification through that approach for native joint primary arthroplasty. For posterior approach, again, there is a slight risk, increased risk of damage to the sciatic nerve and slightly increased risk of dislocation. However, the literature doesn't support that because there is not much difference between both the approaches as far as dislocation rate is concerned and what technique you're going to use. Now, currently, there are a number of ways people are offering surgeries such as robotic, minimally invasive, and you need to know what you're offering to the patients, and you need to be honest with the patient what exactly you're offering to. Coming to the prosthesis, now prosthesis designs. Now we will come to that point, like there are a number of variety of prosthesis available, but what is relevant for this patient, for his age, for functional demands, and for the underlying pathology, as well as the anatomy. And more important is the templating, because before you proceed for surgery, templating or preoperative planning is a part of your procedure. If you template it, if you plan it, then you will be geared and you'll be prepared. You will know what is there available on the shelf, whether that what template shows is available with you on the shelf or not. That will help you to go and proceed with the surgery without any difficulties. And when you are considering the prosthesis, you need to think about survival of that prosthesis and the cost effectiveness. You might have a very good, highly used prosthesis, but if it's too expensive, and then you have to think about it, especially with the current situation in NHS, we do have limitations or with the monetary constraint. So we do have to consider both survival as well as cost effectiveness of your prosthesis. Now, as we were talking about approaches, and I told you like which approach you are going to use, you need to be aware of that. And these are the different approaches for in the different settings for different pathologies. And the most commonly we use in United Kingdom is Harding's approach, which is direct lateral approach, which is called as, or transgluteal approach, mainly used for hemiarthroplasties or dealing with fracture of femur patients. I do personally use for all type of total hip replacement surgeries posterior approach, or posterior lateral we call it. And that is even for fracture of femur, I do use posterior lateral approach for total hip arthroplasty. And as I mentioned to you, the Harding's approach, it has got its advantages. And advantages is it reduces the risk of damage to the sciatic nerve. And although there is no evidence to say that, but slightly it is reduced risk of dislocations. However, there is increased risk of heterotrophic ossification, and there is always difficulty in getting the exposure to the acetabulum properly. Now you need to understand the approaches have got effect on the version, orientation of the acetabulum, as well as the femoral stem. And with this direct lateral approach, you tend to keep the socket or acetabulum slightly more in the retroverted position. And that is opposite with the posterior approach or posterior lateral approach. Now, before we proceed with other questions, I wanted to take you through some basic sciences about the biomechanics. I'm not going to go in detail about the biomechanics of the hip joint because it's a topic in itself. And I'm sure you will read through it for your FRCS preparation. But you need to understand the balancing factors around the hip joint. Now, the acetabulum and the femoral head, they do have a center of rotation, and that center of rotation acts as a fulcrum for joint reaction forces. Now, these joint reaction forces are balanced by the abductors, which are having abductor forces, and the body weight, which has, and these abductor forces as well as the body weight has got moments. And these moments, as you can see here, is from the center of rotation to the abductors is abductor moment, and from the center of rotation to the body weight, which is, I mean, if you know the gravity of body weight which lies in front of the S2, so this moment, which is a body weight moment. Now, when the patient or patient stands on the one stance leg, that is considered that body weight, I mean, the weight of the one leg stance is reduced, then the remaining body weight remains 5/6. And then they would expect you to know this, and they will ask you to draw the free body diagram and explain how this equilibrium is maintained. So in the normal patient, when you are standing on a one leg, then the abductors and the muscles try to maintain the pelvis at the same level or maintain the balance of the pelvis. So that increased abduction force try to maintain the equilibrium against the body weight. Now the moment arm for the body weight is 3 times more than the abductor lever arm or moment arm. And you need to understand that. So this, once you know this, how these joint reaction forces are increased, then you will be able to understand how to perform the well-balanced and sound primary total hip arthroplasty. Now, what happens with the osteoarthritis? Certainly, we are talking about when this biomechanics which we describe, this is in relation to the normal joint, which is articular cartilage is pristine. There's no underlying damage to the cartilage. But when cartilage is damaged, obviously there is a frictional movement, there are increased joint reaction forces, and there's an increased workload on the abductors to maintain the equilibrium. And when that changes with underlying pathology, then how do you balance that? Now, if we are talking in terms of biomechanics, then there are different ways of balancing these joint reaction forces. And there are 2 ways. One is from the abductor lever arm and other from the body weight point of view. How to reduce the body weight moment? So to reduce the body weight moment, either you reduce the body weight, and there are different ways of reducing that, such as if you try to stand in tenderburst, I mean, when patient is walking in the tenderburst gait, then that automatically reduces the body weight lever moment arm. Then that will help to reduce that moment arm. When you medialize the axis of rotation, like when normally you perform the arthroplasty, and when you acetabulum try to medialize it, that will reduce the moment arm for the body weight. And as I rightly mentioned, Tenderberg gait as well. Now, what about abductor lever arm or abductor moment arms? So there are two ways dealing with it, or mainly three ways. Provide the additional movement, such as walking stick in the opposite hand. So that will increase that will reduce the body weight moment arm, and it will contribute roughly around 60% of reduction in the joint reaction forces. Using the suitcase on the same side, which is practically not possible, but this is just for the reason of explanation, how we can reduce the abductor lever arm. And other way is to how to increase the abductor lever arm. So increase the offset, and I will come to the point when we are going through that. What is offset is? Offset is from the center of the femoral head to the center of the abduction attachment. That is the moment arm, abductor moment arm, which is a abductor lever arm. So how do you increase that? Then osteotomizing around the proximal femur, like varus valgus osteotomy, and that will have indirect effect on changing the abductor lever arm. Sometimes osteotomy of the greater trochanter, mainly when first generation Charles totally arthroplasty, it was treated with trochanteric osteotomy as a part of the exposure. And there was a possibility of lateralizing it and increasing the abductor lever arm. And the lateral transfer of the greater trochanter purely to increase the abductor lever arm. And to improve the abductor line of function, and that again, as I said, it is used in initially first generation Charles trochanteric osteotomy approach. So coming to hip osteoarthritis and the arthroplasty. So indications are to relieve the pain and improve the functions, and this is the only indication. Especially when you are in the exam situation or in your real life, you can't promise which you can't offer. And the main indication for arthroplasty is pain relief. You can't guarantee one to improve the function. You don't know whether solving his hip pain is going to improve his function or not, because you don't know whether he has got other problems. So the main indication for offering total hip arthroplasty is to improve the pain and improve his quality of life relevant to the hip pain or hip pathology. You can't promise beyond that. And we all know that Sir John Chanley, who revolutionized the total hip arthroplasty, historically there are other peoples who started developing the arthroplasty, mainly the hip arthroplasties, way before John Chanley invented and revolutionized this. And his principle was low friction arthroplasty. So what was this low friction arthroplasty? Basically, he used very small femoral head, which was 22.225. And the polyethylene which he used, which was again initially first generation polyethylene, was not that great, but obviously over a period of time, it is improved the quality of the polyethylene use. However, while using the surgical intervention, which other principles he used? And first principle was to increase the offset and the lever arm of the hip joint. So what he used is trochanteric osteotomy as a part of the approach. And that helped to improve the line of abductor action and to correct the leg length in the same sitting. Lateralization of the abductors, that will increase the abductor lever arm, that will improve the stability. And another principle he used is to medialize the center of rotation. Basically, when he was putting the acetabular component, he recommended to medialize, and that was during his era, but obviously things have improved or things have changed, and that is not recommended anymore at the moment. Now, how do you look into the frictional torque of the hip arthroplasty? Which are the factors which will help to improve this frictional torque in the hip arthroplasty before we consider all other aspects of the prosthesis or the implants which you consider? So material, bearing surfaces, what type of material which you're using in the bearing surfaces, such as ceramic, cobalt, chrome, which is metal head, or steel. Femoral head size, which is important contributing factor. The smaller the femoral head size, which has got increased risk of dislocation, increased risk of wear and tear, but mainly predominantly related to the dislocation rate. Polyethylene, And if you use the polyethylene as a liner, I mean, currently we are using ceramic or metal on metal when there was an era of metal on metal, not anymore now, not at least in that great numbers. Thickness of polyethylene is also important, because if you use a thin polyethylene, there is increased stress and that will lead to the failure. So that is also important. And the contact, whether it is a peripheral or equatorial contact or a polar contact, and that will have effect on your longevity outcomes as well as the stability of the hip joint. So these are the factors which you need to keep in mind when you are actually performing the procedure, and you need to be prepared. It should be in your mind when you're as you go along with the procedure. Now coming to the acetabular component, now you're choosing the components, and you need to know a little bit more about these components, why it is important, what kind of component you are going to use in your arthroplasty. And while you're preparing, as I said, like John Charnley used medialization of the acetabulum, but it is not required anymore now. It is an anatomical positioning of the acetabular cup. And because of this, there are slight modification in the preparation as well. Previously, we used to see the subchondral bone, which is bleeding bone. We used to break the subchondral plate. And the idea was so that there will be good, A is medialization, and B, there was a good integration of the bone cement. But now it is proven that 3 keyholes are important, which are important and good enough to give a stability to the bone cement integration. And there is no more requirement of exposure of the subchondral plate, because there are many studies which are showing that by exposing the subchondral plate, there is a high risk of necrosis, because as we all know, the cement generates the heat through the and it sets by exothermic reaction, and that heat can cause subchondral bone necrosis, and there will be a fibrous tissue form or fibrous layer form, and that will the cause of one of the failures for the cemented cups. And there is further evaluation in the modern cup, like we do have flanges. The flanges help to pressurize the cement, equal pressurizer, and to compress the cement all around the socket. The grooves, which increase the surface area and binding to the cement. However, deep increased grooves can reduce the thickness of the plastic or polyethylene, and that will lead to the increased stress, leading to the early failure. And the pots are to prevent the bottoming of the cup. So basically, it will help to have equal cement mantle all around the cup, which is very important for the stability of the cemented cup. Now, when you are choosing the femoral components for the cemented stem, you need to understand what is a principle and which are the good cement implants and time tested with longevity, which are currently Exeter and C-stem. We are currently using the AMT stem, which is a modification of the C-stem. But Olden Charnley stem, which had a composite beam, like which has got a relatively rough surface, although it was tapered, with good cement bone integration, but it caused the increased stresses on the cement and leading to the cement mantle breakage or fractures and leading to the early failure as well. Having said that, cementing technique is a part of the success for these cemented prostheses, both for acetabulum as well as femur. And there are still around up to 38 to nearly 40 years down the line, still there are Charnley's stems are still surviving, but the numbers are going down. Exeter and C stem or the AMT stem, which has got a longevity, is very good success rate and less failure rate, provided it has been done with the technically sound way. And the principle of these tapered, these are the polished tapered, and the comparison between Charnley's and the C stem or AMT stem is these are the polished tapers with the tip which is conical, and that helps to have a subsidence in the cement mantle. So there are integration of the bone cement with the bone, and the cement act as a grout. It doesn't act as an adhesive material, or it doesn't act anything else. And the polished taper stem, which subsides into the cement mantle, by a few millimeters, like over a period of at least 2 years or down the line 3 years, and it should not be subsiding more than 2 millimeters. If it is subside more than 5 millimeters, that means there is something wrong and things are not going in the right way. So what happens basically? So when you fill in the cement in the femoral canal and you put the prosthesis, which is polystapled, which is most widely used, there are other prostheses like CPT and other brands, but we are more familiar with Acetabular and C-stem, which is more widely used worldwide. They, when you put the prosthesis in and when patient is weight bearing, the cement dissipate and causes the hoop stress, and that adds to the stability. And that's how the cement bone integration works, and that's how the prosthesis works in the cement mantle. Now, these it is important to understand that C-stem or cemented cups, cemented stems has got an additional advantage. It can give some additional advantage of maintaining the length in leg length discrepancies. It can help with the help of femoral head. It can help to increase the offset, but you need to be careful with the choosing the femoral head, because the femoral head with the skirt is not good, because it will help, it will reduce the range of movement and it will cause the impingement. So you have to try and reduce the using the skirted femoral heads. And I'll come to that point, what is skirted femoral heads are. Now, uncemented stems, like there are different types of uncemented stems, and you need to know the basic principle, how they work. So basically, this is ingrowth and on-growth of the bone, which happens on the uncemented cup. There are different types of uncemented stems as well, which is either hydroxyapatite coated or grit blasted, and you need to go and learn more about it into the basic sciences. Then structurally, they are either proximal fix or they are fully coated cylindrical, which is proximally as well as distally well fixed. And it has got its own pros and cons. And then to add to the stability and to reduce the risk of stiffness, it has got fluted tip. Some of them have got splines with tapered cone. So they all add to the advantage of functionality and long-term survival of those prostheses. However, it has got its own pros and cons with regards to the failures, which will come later, how each of them have got its pros and cons. But it is important, you need to know the basic principles of each of the stem, how they work, how they function. And you need to understand whether you can offer them for every group or every setting, or there are some limitations of using these as well. Now, bearing surfaces, this is also important to understand. And in the exam, they will ask you specifically about the bearing surfaces. And it's very important for you to know the advantages, disadvantages, and available different types of bearings. The most commonly and widely used bearing surfaces, mainly the elderly population or low demand population, is metal head with the polyethylene liner, be it a cemented or uncemented. Like in uncemented, you will have a shell which is of a metal shell, but liner or bearing will be polyethylene. In cemented, obviously it will be a polyethylene with the metal head. Now, the second most widely accepted and widely used, and this is more relatively younger patients, and I'm talking about relatively young is in 65 or 70 years of age group, someone who plays golf, someone who goes out, active, jogging, running, those group of patients, we do consider using a ceramic head with liner. And here you have to balance with the cost effectiveness versus longevity. Someone who is active, someone who is playing golf or doing other sports, obviously their functional demand is high, then you have to think of using maybe relatively expensive ceramic head in comparison to metal head, but that will give you better longevity and less wear rate in comparison with the metal with polyethylene. And we will come to that when we will go through the modes of failure. Now, ceramic on ceramic, it was very popular when it actually came into the market, but it has got its own drawbacks. And ceramic on ceramic liners or bearings are not that widely used at the moment because of different reasons. Although there is new generation ceramics available in the market, still there are problems associated with it if they are not well aligned or not well fixed. then there is increased risk of fractures, breakage, squeaking, early failure. So you need to understand the limitations of using that bearing. Metal on metal, there was a era maybe before 2009 that widely used for each and every patient in active young age group, and for different reasons, it's showed that there is increased failure rate for the metal debris, causing localized reactions, causing systemic increased blood metal ion levels, and that cause alarm in the medical fraternity, mainly the orthopedic fraternity, and the stoppage of totally for arthroplasty metal on metal bearings has been absolutely no-no. Still, there is uses of resurfacing. It is very limited for limited number of patients with very stringent indications, but still resurfacing is still in use where the bearing is obviously metal on metal. We need to know that. So as I said, like cementing is the key for cemented totally arthroplasty for the success. You need to understand, you need to know the generations of cementing techniques. You go along from the first generation where we used to mix the cement with the hand using the spatula. We didn't prepare well femoral canal or acetabulum, leaving the cancellous bone there. We didn't use a good wash or lavage, or we didn't use a method to dry the femoral canal or acetabulum. And we didn't use irrigation suction technique, and we just used inserted the bone cement manually, used as a dough, and we inserted the stem manually with first generation, which is now third to fourth generation we have moved, and which is very advanced vacuum or centrifuge mixing, which reduces the porosity, so that will increase the bonding and polymerization of the cement, which gives a good bone cement integration as well as function of the cement itself long run. Removing the bone from the endosteum, cleaning and drying, using the adrenaline soak gauze to dry the femoral canal, but we not necessarily everyone use the adrenaline soak gauze, but we do use a dry gauze to keep the femoral canal or acetabulum dry. And cement gun used mainly for the femoral insertion with the pressurization. And to avoid the malposition of the stem, we're using the centralizer at the tip of the stem, and the new generation they are using at the proximal end as well, so that the stem is well fixed in the center, and it gives a good mantle around the prosthesis. And the minimum mantle should be all around of minimum 2 millimeter, which is very important. And if you follow all these steps, third to fourth generation, then your success rate of getting a good cement mantle is very high. That means the survival rate of your cemented prosthesis, be it acetabulum or the femur, will be high. So how do you judge whether your cementing technique is good or not, whether the cemented hip arthroplasty had good cementing technique or not? Because that is one of the key factor for determining the long-term survival of your prosthesis. And here is a good example. If you see the uncemented and cemented, both the hip arthroplasties, and the left side, if you see the cemented hip arthroplasty, the Barak describe how do radiographically characterize cementing techniques or cementing methods used. And he has graded at grade A, where you see complete whiteout, you don't differentiate between the cement and the bone. So if you see in this case on the left hip, now mainly if you see, it's rarely difficult to differentiate between the bone and the cement, like it's a complete whiteout. Similarly in the femoral side, but you can see some lucent lines, which I will come to it. As grade B, it says up at least 50% of cement radiolucent line which are seen. Now here, this could be a little bit of air next to the stem here in this bone cement, but you can see some radiolucent line on the lateral cortex of the femur here. However, if you see the rest of the cement, which looks very good, so maybe femoral stem could be grade B, or femoral acetabulum cementing would be grade A. Grade C and D, which is like maybe for some reason you are not focused on cementing technique, or you are in a hurry, or for different reasons you have to choose the methodology or the speed to come out quickly, because obviously cement setting time is different for different types of cement. But while doing that, you end up giving a poor cementing technique. And C and D, they fall into poor cementing technique. That means there is increased chance of high failure rate. So that is very important. You need to understand. Now, coming to next, which total hip prosthesis and what evidence you will support. Now, I was talking to you about how do you assess the primary total hip arthroplasty, which are the areas which you need to look into before you proceed with total hip arthroplasty, and which are the areas to focus. So just to recap before you move on to this question, A is, obviously underlying pathology. You have to confirm that this is a pathology which you can safely provide the total hip arthroplasty. You have ruled out infection, other relative contraindications you have ruled out. And then obviously patient age and functional demand, that will determine the type of prosthesis or type of hip replacement you will offer, cemented versus uncemented. Then obviously all other patient factors you have gone through and you understand that. Surgeon factor, obviously you need to be competent enough to perform that procedure. Then prosthesis factor, local factor, whether there is no variation in the anatomy, no underlying problems related to bone defect on the acetabular side or dysplasia. So you need to understand that, as well as similarly on the femoral side. You need to know, templating is a good way of practicing when you are proceeding with total hip arthroplasty. That will give you an idea whether all the implants available on the shelf or not. Not necessarily each institute follow the same protocol or system. So sometimes you will be missing some part of it, but if you've templated it and if you know which size component roughly and with the margin above or below, then you are relatively safe. And then cost effectiveness as well as longevity. And which are the factors which will determine those longevity of the implant? We will come to that. Now, that's what I'm coming to the point. Now, which prosthesis to choose now, because there are a number of prosthesis available in the market. And relatively, UK or NHS market is regularized by different agencies, and it is looked into it, and it has got a good control over it. But as far as I know, Asian markets or American markets, I'm not familiar with the American system, but my colleagues will be able to tell how their implant are regularized and how they can use that with evidence base. But I'm talking about NHS. So nice, you need to know a few agencies from United Kingdom, because if you're appearing for FRCS exam, it is very important, because these are the things which you know and you use these buzzwords to while you're answering your questions. This will score you high. Now, NICE is the agency which gives the guidelines and sets the protocols. And these are, it's not hard and fast that you have to follow each and every of it 100%, but it is just a guideline. So basically, if you stick to the guidelines, then you are safe. Your chances of failure are less. So what they have recommended, the prosthesis which you use should have 5% or less than 5% revision rate in 10 years time. Now, there are limitations for newly developed or newly researched prosthesis, but there is a provision for those kind of prosthesis as well. And who decides that which kind of prosthesis can be used and which kind of prosthesis should be used in which setting? So those prostheses which are newly developed or recently come in the market, so they are allowed, but there is an agency which decides on that. And that agency is called as the Orthopedic Data Evaluation Panel. We call it as ODIP rating. And everyone knows about it. So ODIP rating decides based on the evidence of regarding that particular implant, the longevity, the survival rate or a revision rate. And based on that, that will give you the idea which is a time tested or a good implant to use. The MHRA, again, MHRA is very important with regards to knowing metal on metal, basically in 2012, the MHRA came with a guideline for metal on metal total hip arthroplasty follow-up because there was an increased incidence of failure rate and metallurgy leading to the tumor-like soft tissue swellings. And obviously there was alarm among and panic amongst the patients. So obviously to get everything under control and to manage those patients, those cohort of patients, MHRA is the agency which came out with the guidelines and the strict follow-up protocols. And that's why ASR, which is one of the resurfacing which has come out of the shelf, which has been completely stopped all over the world. But there are other resurfacing which are still in use, which mainly the Birmingham hip resurfacing, which is still in use. There are certain people still they are using it resurfacing, but strictly for limited number. But when it came initially, I think almost I would say at least every alternate patient was getting used metal on metal total hip arthroplasty. So here you need to understand total hip arthroplasty with metal on metal bearings and resurfacing hip arthroplasty. These are two different things. And the reason why total hip arthroplasty with metal on metal bearings has got a very high failure rate than the resurfacing, I would come to that later. And another thing, if you know a little bit more about National Joint Registry, which is one of the world's largest database about the joint replacements, which is very useful because Joint Registry developed to catch or get early warning signs for early failures. And that's why this become more popular after this metal on metal failure, increased failure rates. And if you use the National Joint Registry data to understand that which bearings, which type of prosthesis or which type of total hip replacement, cemented or uncemented, which has got a long-term survival, whether it is, there are other types of total hip arthroplasty such as hybrid or reverse hybrid. So all these things will be very easy for you to decide based on a National Joint Registry. And when you are in an exam setting, when you are answering the question, if you have read about these different agencies and their recommendations, then it becomes easy for you to support that, because basically when you are answering in the exam, they want evidence, what evidence you are quoting or on which evidence base you are subscribing a treatment or a implant or a prosthesis. And if you go through this, they will help you or support you. So as I was talking about ODIP rating and ODIP criteria for the hip. So just briefly to make you understand, I mean, I know this is a very crowded slide with very complex to understand, but if you can go on their website and you'll be able to read and understand more about it. So basically there are 2-3 very important factors which you need to understand. The minimum number of centers outside the development center. Basically, if suppose, for example, Exeter stem, which was developed in Exeter group of surgeons, if that prosthesis is used outside Exeter Center by more than 3 outside surgeons, like surgeons who were involved in developing that prosthesis, but if it is used outside that group, that and minimum number of cohorts, so that should be minimum number of patients who had used those kind of prosthesis. So 3 for 3 stands for 3 years, 5 for 5 years, 7 similarly 10, and now we are in 13 years. And A star is based on these additional factors like minimum risk, revision rate, and the benchmark achieved, as well as the literature available with RCTs, and that these are the extra factors you will be able to understand. Now, again, ODIP criteria is just a guide. That doesn't mean if you use a 13A rating and if you use someone uses 10A rating, that means 10A is not less, how should I put it? It's not as good as 13A. It's not that way. But anything which has got a long-term good outcome survival with less revision rate, that is good. And normally here people use anything about 10 and above. But there are some group of trusts or hospitals, I would say, they like using 7 or 5. But as long as the revision rate is less than 5 in 10 years, that is more safe. Next evidence which you will quote is a National Joint Registry, as I rightly said, the number of records available and total number of primary nearly 10 lakh total hip arthroplasties with a 15-year follow-up. So this is one of the longest following and large number of total arthroplasty joint registry. The Swedish joint registry is another joint registry you can quote and you can go through it. That is also well regarded all over the world. And following that, Australia and New Zealand registries as well, but obviously Swedish and British joint registries are regarded well as well. So coming to the revision rate, now failure rate, I would say. Now the percentage of primary total hip arthroplasty failures for different types of arthroplasties, all cemented, if you see here, it's roughly around 28%, and most commonly is metal on poly. The other revision rate is relatively less. Ceramic on poly is less percentage wise. Similarly, if you compare between cemented and uncemented, the cemented percentage of fixing or bearing, you can see the number, highest number is around cemented. Then now we are catching up a little bit hybrid. What is hybrid primary arthroplasty is? Now, as we all know that for acetabulum, cemented cuff fails by shearing force. The cement doesn't work or function well with the shearing force. It works more better with the compression force. And that's why there is increased failure rate for the cemented acetabulum cup. So then in hybrid, we use the uncemented shell or acetabular shell with different bearings, be it a polyethylene or ceramic bearing, and cemented femoral stem, and that is hybrid. And the reverse hybrid is opposite of that, which is cemented cup with the uncemented femoral stem. And if you see the number of arthroplasties for most widely in this country, because majority of the patients are in the age group of around average age group for patients undergoing total hip arthroplasties around 70 and plus. So certainly the cemented prosthesis is more widely acceptable. Different reasons. I will tell you when to do cemented and when not to do cemented or uncemented, I would say rather. Now, this is another evidence from the National Joint Registry, which will help you to understand. And if you see the revision rate, this is a revision rate at like different years, like as you go along up to the 15 years. So, and if you again see that cemented arthroplasties are having less revision rate than uncemented, and hybrid is catching up to the cemented. So hybrid is becoming relatively more famous as you go along. People are using hybrid prosthesis more. And this is a good evidence to quote, saying that you can say, I mean, how do you structure your answer when you answer saying that which type of prosthesis, which type of bearing you are going to use? You can say that I'm more familiar or more comfortable using the posterior approach. I have been using and more familiar with the cemented total hip arthroplasty. I have been widely using metal on polyethylene or ceramic on polyethylene bearings for different reasons or based on NGR data that it has got a better long-term survival rate or less revision rate. So if you frame your answer in that way with some evidence and I do use so and so prosthesis based on ODIP rating, then you are answered everything what examiner wants to know, so that you are leading the examiner rather than examiner leading you. And then they will come to the next other evidences such as any randomized controlled trials or any other publications, which if you quote, then that is high scoring answer. Now, coming to the follow-up now, we have decided already which prosthesis you are going to use, what evidence you are going to use, and whether you're going to use cemented or uncemented. Before we move on to next question, sorry. I just want to recap about which prosthesis to use and how do you decide now, because obviously it is a very wide range to decide. So what we follow in NHS and here locally is because based on these different agencies and guidelines and protocols, Elderly population, and elderly here I'm talking about anyone above 75, because 60 and 70 is still relatively young. They're very active in this age group. Majority of them I'm talking about, not everyone. With some sports activities or some activities they are doing. So for them, 70 and above, we strictly use cemented total arthroplasty. Anyone between 65 to 70, again, either you can go for hybrid or you can still use cemented total arthroplasty. And I'm talking about both cemented acetabular as well as cemented stem. However, someone who is young with this patient, which we talk about 63, and I'm going to come towards the end, which prosthesis we're going to use for that patient. But if we have to answer for this particular case, which we started with, he's 63, he's quite active, he's still working, although he has got comorbidities. I will consider offering him uncemented total arthroplasty. And he has got underlying avascular necrosis as a cause to develop this arthritis. So uncemented cup, uncemented stem with ceramic on polyethylene bearings or liners. Now, someone who is young, who is active in 60s or less than 60, I would consider doing uncemented both stem as well as the cup. Someone who is between the 60 to 70, who is in the borderline, active but not functionally highly demand, not working, then I would consider doing a hybrid, which will be uncemented cup with the cemented stem. Now, some age group, dysplastic hips or very young patients with, for different reasons, developing early arthritis, there are some centers and some surgeons, they are still doing or performing the resurfacing hip arthroplasty, which you can still say that. And safe answer for that would be based on MHRA guidelines as well as National Joint Registry, and you can quote NICE guidelines. The hip resurfacing still can be used, but there are strict indications and strict contraindications for that. So as long as you know those, then you are safe answering or saying that hip resurfacing for very young age group. And one of the famous example would be a famous tennis player from United Kingdom, Andy Murray, who had resurfacing done and who is trying to return to the sports. But the reason I'm giving that example is because the patient should be very young and should be as active as he is. Like, I'm not saying highly competitive sport, but someone who is doing a sports as a routine activity. Now, you're seeing the patient after having a total arthroplasty, and what you are looking for, what do you see them, I mean, when they come in the follow-up in the clinic. So you just ask them clinically by taking the history, how they are feeling, how they are doing with the hip. If they are pain-free, they are asymptomatic, then what you look on the X-ray, you look for position of the prosthesis, you look for any lucencies around the cement mantle, bone cement integration area, and you see any lucencies around the cement prosthesis region. So these are the things which you look. So clinical presentation is most important thing. A patient is asymptomatic and patient is happy with the total arthroplasty, then you just need to look for the X-rays. And the follow-up protocol we follow here is first follow-up after having a total arthroplasty. The average inpatient stay for total arthroplasty based on the patient's other general condition is on an average is 2 days to 3 days max. Then first follow-up will be in the 6 to 8 weeks time. The clips or sutures would be removed in the community, or sometimes there are different centers that have set their wound clinics purely because they should be point of contact for any wound related problems in the hospital, so that the operating surgeons get to know what's happening with the wound if there are any issues around. Then 6 to 8 weeks follow-up with the X-ray on arrival, and we do get that time AP, anterior, posterior, and lateral views, because you get to see the cement mantle, versions, positions roughly, and rough guide. Then next follow-up would be straight away after a year. And some centers, they do discharge at 1 year based on how patient is performing. Some centers, they do follow up to 5 years. So because currently the number of total arthroplasty patients are high, the volume is high, then we are more pro to discharge them at 1 year depending upon their clinical picture or outcome. Each and every patient does pre-operative and post-operatively patient-reported outcome forms, which includes the Oxford hip score, Harris hip score, and that is purely for academic purpose to know how the patients are doing, and that is a good way of knowing patients' outcome. And those are patient-reported outcome measures, so that is more reliable, widely accepted. Now, suppose the scenario is different. Patient had this total arthroplasty maybe 10 years or 15 years down the line, and this is a very painful total arthroplasty. Patient is in late 70s or 75-year age, coming with painful total arthroplasty. So what you look for? So you start with the good history, knowing what is the duration, onset, duration, and progress of this pain. How does it affect in activities of daily living? How patient is affected with this? Then you are worried about infection first. So ask whether there is any focus of infection, whether there is any recent history of infection. Then ask whether there is any history of any injury or any fall, anything which has aggravated the pain, whether there is any associated fracture following injury. Then the nature of the pain, whether it is dull ache, sharp shooting pain. Obviously that will help to know whether if it is acute and sharp pain, that means there is something not right, which could be infection or which could be something else. And what are the relieving aggravating factor? Because if it is relieving with lying down or non-weight bearing and aggravating with weight bearing, that means there is something wrong with the prosthesis. Either it is loose or something is not right related to the fixed prosthesis. And if you go through the different literature, there are different reasons why the painful causes of painful total hip arthroplasty. So non-hip pain is nearly 24%, and mainly the spine. Majority of these patients will have a degenerative spine disorder, and you need to rule that out. You need to basically that clinical assessment is the most important key. Taking the history and clinical examination is the most important thing. The other causes, most common cause is other more common causes are periarticular, like such as impingement based on, but that is more common in the early stages of follow-up, like such as within a year or 2 years time. Impingement secondary to the loosening or change of position of prosthesis is again possible, but mainly the psoas impingement is more common, one of the most common causes for that. But that is more common again with the uncemented prosthesis or cemented with change in the position secondary to the loosening can cause these impingement. The other causes of impingement could be related to the positioning of the prosthesis, size of the femoral head. There are different other causes, but that is not as high as the anatomic periarticular causes. Now, loosening is one of the most common cause, and truniosis and metallosis is more common, mainly related to the metal on metal bearing surfaces. It's not as common as loosening related to the wear. Now, we will come to that wear, which is leading to osteolysis and aseptic loosening. That is one of the most common cause you see down the line, someone who had total arthroplasty more than 10 years, 5 or more than that. Microinstability, micro instability could be acute onset, which you will notice early, like, if position is not right, either subluxating or dislocating hip, or microinstability secondary to wear. Sometimes the polyliner is worn out, and then the articulation is changed, and that can cause microinstability. Or if it is crack or fractured ceramic liners, be it a femoral head or the acetabular liner, that can cause microinstability. But mainly the wear and loosening secondary to the wear are these most common factors or causes leading to the different modes of wear. So coming to that now, if you go into NJR data, see the most common causes of loosening, and as you come along, the pain is the most common cause for revisions, all causes of revision, but obviously pain is always secondary to some underlying condition. And if you see the different reasons, aseptic loosening or lysis is the most common cause, followed by different wear patterns. Dislocation is another most common cause. Infection is again around 13.8%. It's quite high, but yes, that is one of the cause. Periprosthetic fractures, again, in the very elderly age group with osteoporosis, with trivial trauma, we do get, equally you would be surprised. Our cohort of patients are equally fracture neck of femur, like as equal to as fracture neck of femurs. And from this year, now Blue Book, or we call it as fracture neck of femur guidelines, they have included these elderly patients with periprosthetic fracture at par with, they should be treated at par with fracture neck of femur. So that means they should be prioritized and should be operated within 36 hours. So if you look into NJR data again, you will get to know what are the different causes of failures or revision rates in NJR, and that will tell you the whole picture, like what are the most common causes of revisions for following the primary total hip arthroplasty. So they will pose you a question in the Viva setting. I mean, this is basically a Viva on adult hip pathology or adult reconstruction. Describe the different modes of failure following a total hip arthroplasty, or different modes of failure for total hip replacement. And you should be very structured. Your understanding needs to be very clear while you are answering these questions, because this is very important. And this is very easy to score, because you don't need much complex situation to answer, or complex understanding about it. So what are the modes of wear? You need to understand basic science, and I suppose those who are preparing for exam would either go through it or must have gone through it already. For rest of the practitioner, this is very basic, but which is very important, relevant to the FRCS. So most common mode of wear which we see in day-to-day practice is mode 1, generation of wear debris, basically most commonly seen with the metal on polyethylene liner. And that wear debris leads to the osteolysis, and you need to understand the cascade of osteolysis as well, which I'll come to next slide. What happens exactly, how the wear particles activates the macrophages, leading to the activation of osteoclast and resorption of the bone, which causes osteolysis. Now, first generation of mode is where there is a contact or motion between the two bearing surfaces which are intended by designer, which means like either wear between the metal on poly, which is most common and more pronounced wear than others, such as ceramic on ceramic, or ceramic on poly, or metal on metal. But basically intended for primary bearing surfaces by designer. Mode 2 will be the primary bearing surface against the secondary surface, not intended by designer. So what does this mean? This means, like, suppose if you have got a uncemented cup with the shell, with the polyethylene liner and the metal head. So metal head, which is articulating with the polyethylene liner, which has worn out, and it has worn out so severely that now metal head has gone through the polyethylene and now articulating with the shell. So basically this was not intended. Intention was to have a bearing surface between metal head and polyethylene, but because of the wear and the poly is completely worn out, now metal head is going and articulating with the shell. So this is a mode 2 failure, where intended surface with non-intended surface. Now mode 3 refers to two primary surface with third body interposition. So basically we call it as a third body wear, such as it could be anything, any bony particle, cement particle, or any metal debris which is generated is coming between two bearing surface contacts and causing the third body wear particle. So that is also, but that's not very common in comparison with the mode 1 wear. What is mode 4 wear? Mode 4 wear means both the bearing contacts were not intended to articulate with each other. So two non-bearing surfaces, non-primary bearing surfaces rubbing with each other. So what is this example of? Like most commonly we call it as a backside wear. So what happens is suppose polyethylene liner into the metal shell, and those are there are small holes into the shell. Now there are different ways of sealing those holes using the either screws or the wax, or different ways of sealing those holes, so that wear debris which is generated from the polyethylene doesn't go behind the shell and causes the osteolysis. So that kind of thing. Or fretting and corrosion of the modular taper connection. Suppose metal head which sits on the femoral neck, and that is truniosis, can cause metal debris, and that goes and causes the wear. Or suppose if you're using the screw to fix the shell into the acetabulum, and that uh, metal which is causing uh, part of the articulation and leading to the mode of failure. So it is important to know these different modes of failure, because then you have a better understanding how the total hip arthroplasty can fail and what are the different modes of failure. So briefly, you need to know what do you mean by wear and what do you mean by corrosion. It is very important because this is a basic science and you need to know thorough, because when you are on the viva, it can go in any direction. But obviously, as an examiner, they have been strictly regularized. They have got a chart and they are not allowed to go beyond the territory of answer which is expected on that question. So the question and answers are set for the examiner now. The older days, examiners were allowed to go according to their way, the way they want, but now examiners are not allowed to go out of the setting. So questions and answers are already given to the examiner. So as long as the candidate answering the question within the given framework or expected answers, then they have to either tick for or against it. So coming to the point, what does wear means? What are the different types of wear? Obviously, you need to understand briefly what does wear means. So basically, it's a progressive ongoing loss of substance from the material, and it could be secondary to the mechanical or chemical factors. So it could be mechanical failure, it could be chemical failure such as synovitis or any abnormal fluid which is coming through in contact causing the wear. So adhesive wear is when two opposing surfaces are in contact, that can lead to the adhesive wear. Abrasive wear is, again, we just discussed briefly, two body or third body particle wear, which can lead. Fatigue wear, again, you need to understand, mainly if you know the wear of the polyethylene, that can be related to the fatigue wear. Corrosion, again, you need to know what is corrosion means, like it's dissolution of the metal in a solution. It's a electrochemical mechanism, and you need to understand the principles and mechanism of it, and different types of corrosion which you need to know. So this is relevant in terms of knowing and understanding the different modes of failure in total hip arthroplasty. And more relevant in this case would be the wear debris and wear particles, which is very important. So what happens if you want to know a little bit of cascade? You need to describe this cascade. You may not be expected to explain the cascade as a part of the answer, but if you answer, then examiner will be quite impressed. Then he would know that what kind of next question he should answer, because you yourself are setting standards high by answering these questions. That means yourself answering high scoring answers, then examiner is bound to take you to the high scoring questions as well. So these wear debris or the wear particles, be it from polyethylene, or which is most common, or metal debris. So they are in the different sizes, and it is number of wear debris, the volume of wear debris is proportional to the size of the particles. And these size of the particles is between 0.1 to 10 micrometer. And the macrophages get activated with these small debris particles. And if the size of the particle is in the range of 0.2 to 0.5 micrometer, then macrophages get more activated because they can engulf those size particles very easily. What happens then? Once the macrophages get activated by engulfing or taking these particles, then they release the cytokines, and these cytokines which goes and activates the osteoclasts, and these osteoclasts then go and start resolving the bone, and that's how the osteolysis starts, and that is reflected on the radiograph or X-rays in the lytic zones or lysis around the stem or the socket, which is reflected in the X-ray. And this is ongoing chronic process. It's not acute process which you'll see immediately within a day or within a week. So what is aseptic loosening? We have just learned about lysis and aseptic loosening. However, each and every case has to be treated in isolation. You can't use generalized things. each and every patient coming with a painful total hip arthroplasty, you have to rule out infection. And how to rule out infection is clinically as well as some invasive, some small procedures before you proceed or before you think of doing any major surgical intervention such as revision arthroplasty. So if you look at these two X-rays, they both are cemented total hip arthroplasties, but they both are from different generation. The right side, a total hip arthroplasty, if you see here, I mean, if you want to be critical of this, then see the stem is slightly in the varus. The tip of the stem is not in the center. That means there is no cement mantle between the bone and the tip of the prosthesis. So that means it's going to cause early failure by this because there's no cement mantle. So it can cause lysis and break to the cortex here. And then it will be more stem proximally is more on the calcar area, so it will cause more stress on the calcar area, can lead to the fracture or can lead to the failure of the stem. If you want to comment on the cementing technique, this is a good cementing technique here. You can comment on the positioning of the cup. Yes, I mean, version and position, abduction of the cup. Again, that is very important, which you will determine in the templating, how to do that. I'm not going to go through the how to perform the good primary total hip arthroplasty. I'm talking more relevant about the basic biomechanics and mainly the modes of failure. Now, if you are coming to the left side total hip arthroplasty, now this is Charley's elite stem and then acetabulum. If you see the different zones which will come to which are, how do you classify them into different zones and how do you describe them in the exam? So that will be more relevant, but you can see this zone 7, zone 3, 4, and 5 lytic lesions, again 6 as well. And in acetabulum side, you will see again all 3 zones there is osteolysis, means the both acetabulum and the femur are likely to be loose secondary to the osteolysis or aseptic loosening. So these are the different zones of failure, and you will describe based on these zones. So for the femur, both in AP and lateral, Gruen described these zones, and these are 14 zones altogether between AP and lateral. And remember, 1 and 8 correspond to the greater trochanteric region, and 7 and 14 corresponds towards the lesser trochanteric region. Rest of the number you have to follow through. And similarly, Dilly and Charley describe the zones for the acetabulum to describe which zone is affected. And that would be very clear when you're answering the question. And when you're answering the question, you can describing the radiograph showing the different zones and which are the zones affected, then that will help you to determine whether prosthesis is completely loose or prosthesis is fixed proximally but loose distally, or loose proximally and well fixed distally, because that will have the modes of failure for femoral stem. Similarly with the acetabulum, the zones of failure and bone loss will help you to determine and plan for revision total hip replacement if it is symptomatic. Now, you don't treat the x-rays because sometimes x-ray can be scary, but if patient is asymptomatic, you don't need to do any intervention in that point. So always clinical assessment, history taking, clinical examination is very, very important. So when you're answering the question, you should always answer in a way that I will take the detailed history, examine the patient in the clinic, and do the further investigation in the form of blood inflammatory markers, x-rays, radiograph. If you need any further investigation accordingly, you should mention that. So that will be more holistic approach rather than just commenting on the x-ray. However, in the exam setting, examiner will lead you saying that, okay, you have done the clinical assessment, patient is having symptoms, patient is affected by this pain, and these are the x-ray pictures, then yes, you should lead further. Now, modes of cemented femoral stem failure. Now, I'm talking about these mainly the cemented component. I did mention that it's mainly about the cemented total hip arthroplasty modes of failure. And there are 4 different modes of failure, but Type 1, which is again divided into two subcategories. Type 1 is pistoning. So what does pistoning means? Now, pistoning means the stem which is moving in the cement mantle. So as we have understood that the cement acts as a grout, the cement forms a good integration with the bone. So the cement and the bone are well fixed, and the stem, which is polystaper, which is subsiding into the cement. Now, as I said in the beginning, the subsidence should be 1 or 2 millimeter within initial 2 to 3 years. If subsidence is more than 5 millimeter, that means there is some problem. There might be some breakage of the cement mantle. There might be less cement mantle on one area around the tip of the stem, which might be touching the cortex or breaking the remaining thin cement mantle. And that could lead to the loosening of the stem or loosening of the prosthesis. So in the first one, pistoning type, stem is within the cement. So there is subsidence which is high. The subsidence of the stem, which is too low, and then you will see from the tip of the greater trochanter and the shoulder of the stem that it is subsided more down. And that you'll be able to see with the serial X-rays in the regular follow-up. Now pistoning, and this is how you will assess radiologically. Now this is the shoulder of the stem, and this is trochanter. And if you measure this distance in the serial follow-up X-rays, you will be able to assess how much subsidence this stem has got. And as I said, like if it is more than 5 millimeter, that means the stem is loose, or there is more subsidence. That means there is some breakage in the cement mantle, and that you need to look for all around the prosthesis. And that causes instability, which will lead to sclerosis and thinning out the cortex on the lateral side with the tip of the prosthesis with stem in cement. The next is both cement and the stem, both are within the bone, and that kind of leads to the radiolucent line, which you'll see all around the prosthesis, and that will lead to the failure of the prosthesis, which either it will be fracture or it will be breakage, depending upon the stress and amount of fatigue it goes through. Now, medial mid-stem pivot. So basically the pivot is in the medial side of the mid-stem. So what happens is, proximal medial side and distally lateral side, there is a toggle or a movement. So the tip of the stem is laterally hitting the cortex, and which is causing some sclerosis. And similarly, there is more load and pressure coming on the medial side, on the calcar side. And stem is pivoting around the center point here, somewhere here. And that causes medial migration of the proximal end and the lateral migration of the top end, which leads to the instability and pain, and which can lead to further, depending upon the load and pressure, either it can fracture or it can break, secondary to these changes. Now, calcar pivot, this is not very commonly seen in the cemented stems. This is more common with the uncemented stem. And it's kind of a windshield wiper effect, basically. And distal stem, which toggles more, which leads to either fracture or breakage around the collar. Basically, it can, because of this toggle, there will be more load on the calcar, so which can break there, or it can break at the tip. And that's why it's more pivoting this collar on the calcar side. So there's a high risk of fractures there. This is more commonly seen in uncemented stems, and this one of the example is Austin Moore. Now, cantilever bend, and I have seen quite a few cases of cantilever bend. And what does cantilever bend means? Cantilever bend means the stem, which is well fixed distally, and there is some loosening around the proximal end. Either there is a breakage of the cement mantle, or there is osteolysis causing to the no support in the proximal aspect of the stem. And because of that, continuous load leading to the deformation, which results into the breakage at the more fatigue area, with the more stressful area. And that's why these stems fail with the fractures. And you'll be surprised that this distal stem is how well fixed, because I've seen some of these cases they were so well fixed that we have to do the osteotomy to remove it. It's very difficult to remove those well fixed distal portions of the stem, and that is cantilever bend. I think these are the main, most commonly seen modes, which I have seen is more of a cantilever bend and a type 1 pistoning, which is mainly stem with the cement. So these are the most common ways. Calcar pivot, again, is not very common these days, at least maybe olden days when cementing techniques were not right or prosthesis were not right. Again, based on the prosthesis type as well, because this is subsidence which you'll see with the polished taper, but not with the elite stem, because those were metal rough surface. So I think that concludes the modes of failure. So I hope you will be able to answer the questions which we had posed in the beginning, like which factors you will consider when you are offering for total hip replacement. You need to know a little bit about the biomechanics of the hip, what is abductor lever arm and weight bearing moment arm is, and how do you balance that, what happens in osteoarthritis or any arthritic pathology, and what evidence you will use while deciding the hip arthroplasty cemented versus uncemented, what kind of bearings, based on what evidence, and then subsequently you should be able to describe the different modes of failure for cemented total hip arthroplasty mainly. I hope that is clear to you, but I'm quite open, happy to take some questions.
Thank you, Dr. Satish. What a comprehensive presentation. I mean, if I allow you to speak for another 1 hour, I'm sure you're going to speak for it.
No, thank you very much. If I was more running over time, then sorry about that, didn't realize, but
no issues, absolutely, because I can see the passion in your lecture. I mean, that's really appreciating. And there are a couple of queries. I mean, I'll just one query from my side is regarding the ODIP rating. So when someone says 10A, that the implant is being checked for last 10 years, and A means excellent evidence. Is it right?
A is based on, yes, in general term, you want to use it, yes, excellent result. But there are different subcategories as well, because if you're coming to 10A, again, because they have made it complex. When initially the ODIP rating agency came out, it was very simplistic, but they have made it more complex to understand, but there are different reasons why they have done it. And to make you understand here is, A stands for like A and A star. These are the two things, like, to differentiate mainly between. And B is, again, there's a less evidence, or number of prostheses used in total is less. So basically what is more important is to consider A is more than 3 centers which has used outside the developing center, and more than 3 surgeon cohort, like those who have invented the prosthesis. It has been used by more than 3 different surgeons. And that makes more towards the A. And obviously the number of prostheses used goes up from 150 minimum for 3 to fall into category to 500.
Okay, and there's something called as a star rating, is it?
Star rating is based on evidence, basically randomized control trial evidence, or just a case series. Case series carries less weightage against the randomized control trials or meta-analysis. And if that is the evidence for those kind of prosthesis, then that carries A star weightage.
Okay, and can you mention few which are the implants that have the best ratings?
I mean, currently widely used and in long-term use, 10A, certainly 10A, and some of them are 13 are Exeter stem. Then C stem, AMT stem is around 7A yet, but CPT again 10A. So these are the femoral stems, which I would say. And Corail, again, Corail is in the long run. So, I mean, which I know, that's why, there might be another one, many of them, but they are widely used, and these are above 7 and 10 ratings.
Okay. Senthil, you have any questions?
Yeah, it was a nice presentation, Doctor.
Yeah, thank you very much, Senthil.
So the joint registry shows that the revision rate 10-year and 15-year is more for uncemented compared to the cemented. And
Yes.
like I'm in Dallas, US, so we do most of our hips done in this country are uncemented hip replacement. And yes, so the higher failure rate seen in the registry, is it because of the selection bias? You said that uncemented is a choice for UK surgeons when it comes to young patients. So is it because of the selection bias, you think?
It's very difficult to say. I mean, it's a good question, but it's very difficult to say that there is a bias because there is no restriction on the surgeons. Although these are the agencies, they have set the guidelines and protocol, but no one is watching you that closely that what prosthesis you are using based on what. Certainly, being in NHS, it's kind of a government agency. We do have limitations of you have to look for cost effectiveness as well as the long-term survival. And that makes us use less cemented prosthesis, to be honest with you. And that is one of the reasons why people are using less purely because of the cost reason. If you're asking me, maybe 10 years back or maybe 5 years before, when NHS was not constrained with the financial burden, then maybe uncemented uses was more than the cemented one. That could be one of the bias. You should say cost is one of the restricting factor to use more uncemented one. But if you see the evidence, like, yes, you can say that because you haven't used more, then certainly your revision rate is high because your surgical skills are less. Because if I have done more cemented than uncemented, certainly you can question my surgical skill using the uncemented prosthesis. And that can have effect on the revision rate or outcome as well. And if you see the worldwide literature outside our NGR data, then yes, people will have the literature showing that there is not much difference. But obviously you have to have a case mix and match, because you can't compare young age group against the adult age group because indications are different as well.
Mm-hmm. So yeah, thank you. I have one more question.
Yeah.
Like cemented hips, like in uncemented, we always trial it and we get a nice press fit and we know we are happy, we go with it.
Yeah.
In cemented hip with dorsal femur, where you cannot trial with the femur being so wide, what's your technical tip for those kind of patients?
I mean, no, sorry, I couldn't get that. You can't try with the trial.
Because when you put a trial in there, it's loose in there because it's dorsal with very minimal cancellous bone. And how do you? So we used to wrap the gauze around it and to get a little purchase. So what's your tips and techniques?
Now I do understand what you're saying, because dorsal is like it's an open tube. However, what my experience is, we do get larger broach, like bigger size, and we still try, but I haven't come across any difficulty that all the broaches become loose when you're trialing. They are well fixed, and that's how we determine the size, as you know, for the cemented. So I haven't come across that difficult situation yet, that the stem broach was so loose that I couldn't try the trial.
So you don't mind going even to a 18 or a 19 stem, and because some of them are so wide canal.
Yes.
Yes. Okay.
To my level experience, maybe your experience is more than mine related to the using these trials, but I haven't come across anyone more than 16, to be honest with you. I have tried up to 16, but for that there is a genuine reason as well, because patient was tall, patient was big enough to consider 16 as adequate size for that. But someone elderly in late 70s or 80s with wide canal, they don't go beyond like 12 or maximum 14, I would say.
Oh, okay.
But trial with that, yeah.
Yeah, on this side of the Atlantic Ocean, most of the time we are using a 14 for a simple primary cemented stem, and when it comes to uncemented stem, so when it comes to cemented, we are usually in the 18, 19 territory. So big patients we have.
True. I can understand, because obviously the patient groups and sizes are different. Like similarly, it is not applicable for the Asian group, because then we have to think of using Asian stem in some of the patients with the DOR A or DOR B, because when such a narrow canal, you can't get size 1. So in that situation, you should be prepared with either DDS stem or Asian stem as well. So it has got both the ranges you have to answer. But to answer your question, I have gone up to like maybe 16 maximum. That is one or two of patient, but majority of them, they fall into 13, 14 sizes for trial.
Okay.
Yeah.
Dr. Satish, one question, and to Senthil as well. See, there are a lot of RCTs that have looked at uncemented versus cemented, and they found that the incidence of periprosthetic fractures are slightly on the higher side with uncemented.
That's true.
Yeah, I agree. That's on the femoral side. Yes.
Yeah.
Then why is the reason when there is strong evidence to say uncemented doesn't fare well as much as cemented? So why do you think uncemented holds good?
Because the revision rate, 10-year and 15-year revision rate is going to be same irrespective of whether it's cemented or uncemented. Most of these complications happen in the first year. So after that, it kind of evens out. And like like when you take a cemented stem out, we have to go much distal, so that means wherever the cement had interdigitation, when it's going to be sclerotic, and in order to get a purchase, you need to go much further down. So when you do an uncemented stem, and if you have to revise sometime down the line, we still have bone stock, is my opinion about it, so.
I mean, if you are done with Senthil's answer, then I would say the focus for uncemented stem is getting a press fit. And sometimes experience comes here because, as Senthil rightly said, they're doing more uncemented, so they might be more good at it using uncemented prosthesis, because it's very difficult to miss that sound, change in the sound. And the moment you miss that sound, then yes, you are inviting a trouble of intraoperative fractures. That is one of the reasons why, because the principle of uncemented stem is based on a press fit, and that press fit, to get that press fit, it has got a learning curve to understand that.
Yeah. The first few years of my practice, I was using uncemented for everybody because that's how our training is.
Yeah.
And then with accumulating data towards higher periprosthetic fractures in octogenarians and elderly patients, now like I try to push for a cemented stem in people who are at least dorsey and who are like above 75 and things like that. So,
at least based on NJR, if you see now, our trend is changing from cemented to the hybrid. Hybrid is trying to catch up towards the cemented side. And that is purely because mainly the revision failure rate is high with the acetabulum rather than the stem. Many of the new generation C stem or AMT stems, they are far better, or Exeter stem for that matter, or CPT stem. So they are still well fixed down the line, 15 years, 20 years, but the failure is mainly on the acetabulum side. And the focus is now changing towards the hybrid total hip rather than cemented total hip.
I have one more question, doctor. When it comes to using a high offset stem or a posterior lip liner, what's your take on it? Or a larger head? What's your practice pattern?
To start with, like lip liner, if it has to be lip liner, obviously that gives a flexibility, changing that liner with uncemented cup, because you do have that modularity. With the cemented cup, there's no forgiving because you need to be very quick before cement sets. So all these things come with the templating, trialing, and you need to determine a version and all those things, because if you go wrong with the version of your cup, then that's it. You're stuck. You can compromise slightly on the stem side, but even if there is a limitation how much you can compromise with the version. So that is one limitation for cemented cup, where lip liner or elevated liner uses. We do use the elevated liners or elevated stems sometimes based on the anatomical variation. If you are intraoperatively fine that there is not much support, or you feel that you are going to struggle with getting right version for the cup, then yes, you can use elevated cup. But routinely, I haven't come across that difficulty, to be honest with you, because most of my arthroplasties are cemented. And as you are more comfortable with uncemented left, right, and center day in, day out, I'm more comfortable with cemented day in, day out. And it's a matter of exposure, experience to the surgeon. But these are the technical tips, I would say. Coming to using the offset, obviously, again, I go with the template, and preoperative templating helps me to understand high offset versus standard offset. There is a little bit of modularity which you can improve with. However, with the template, you can change your cup positioning. You can, medialization is no more now. At least majority of the new generation surgeons are not medializing the cup, more anatomic positioning rather than medializing. Offset, the femoral head gives some flexibility or modularity to increase the offset. But again, I will try and avoid using the skirted heads because that reduces the range of movement and that increases the impingement. So I would be careful with that. So to begin with, I will go with the trial with standard and offset, and intraoperative trial helps to decide whether you are opting for high offset stem or standard stem. And still, if you need to adjust on top of that, then obviously you can adjust on the head side because you're already committed with the cup before that.
I think, Dr. Satish, I think we have ordered with the questions. I mean, we have addressed most of the queries that have come up in the chat box, and thank you so much for your time with us, Dr. Dhotare.
Yeah, thank you very much. Senthil, this must be very, for you and Senthil, it must be very basic. And it was very difficult for me, but I literally had to remember my exam questions before I could set this presentation. I wanted to make it so basic that it should be, you should feel that you are answering for exam or preparing for exam.
Very true. It has been, you have covered almost everything.
Yeah, it's an excellent presentation, Dr. Satish.
Thank you.
Like
Thank you
I
very
can
much.
see how much effort has gone into this. You have covered some of the basic aspects of low friction arthroplasty and the modes of failure. So it was very good, actually. Thank you.
Yeah. Thank you very much. Thanks.
Thank you, Dhotare. So we'll look forward for more from your side. And
sure, definitely.
Today, let's bid goodbye.
I hope you all stay safe with the COVID, and nice meeting you to both of you. Thank you very much.
Thank you. Thank you, Dr. Satish. You take care. Yeah, you stay safe. Bye-bye.